Okay, hello and welcome to June's Cyber Briefing. I'm Lauren Frickel, Marketing Manager here at CynergisTek. A bit of quick housekeeping before we begin. There are a few buttons on the left side of the screen that we'll use today. You can use the chat button to engage in conversation with the entire group. For example, if you see a colleague or peer in the audience, feel free to say hi there in that chat function. Use the Q&A button to post your questions you have for our speakers or on the topic. We have planned for a Q&A segment at the end of Andrew's session. As a heads up, this briefing is being recorded and will be available to stream here in this Eventry platform by the end of the day. Also, for any of you who are new and would like to look back at previous briefings or previous briefing slide shares, we will be sending a follow-up email with those links, and I will also drop those links into the chat right now. Now, before I turn the mic over, I ask that you, our audience, remain muted and keep your cameras off until we get to a Q&A segment. During the Q&A segment, please feel free, if you'd like, to engage on camera and on your mic. Now, let's start today's session. Mac, I will turn it over to you.
Okay. Thank you, Lauren, and welcome everybody to our June cyber briefing. Today, I'm joined by one person that all of you have already met, who is Andrew Mahler, who heads up our privacy and compliance group at CynergisTek. You might recall that Andrew has spent time at OCR as an investigator. He spent time at two prestigious academic medical centers as their privacy officer. And what I learned recently is that Andrew, for the last 6 years, has been developing content in health law and instructing at the University of Arizona. So kudos to Andrew for giving back to the community that has done a lot for him, obviously. The second person that's going to join us today is new to the audience, and that's Jon Benedict. Jon is a medical device security principal at CynergisTek. He works in our medical device security practice. Jon has a lot of experience with medical devices. He worked at organizations that you're probably familiar with by the names of TriMedics and Intermed, GE Healthcare, and Securion. And so Jon brings a lot of experience both from the service perspective in terms of working with the clinical engineers that rely on these systems to support the caregivers, as well as the network and IT security folks who are worried about making sure that these devices are doing what they're supposed to be doing and are secure. So Jon's going to be talking about medical device security today from a very practical perspective. And Andrew, if you recall, is going to be following up from a conversation that he started last week with the 21st Century Cures Act. And he's going to be talking about the 8 different exceptions that are related to that rule in terms of blocking and explaining that, as we said he would during our last meeting. So, Sophie, can we go to the next slide? Because first of all, I'm going to give kind of a brief cyber update, if you will. Go to the next slide. One of the things that I do quite often, and I think I've said this to a lot of audiences over the years, is, I start every day by reading what's going on and paying attention to what's going on in our industry to try to understand the trends and the things that we need to kind of incorporate into our daily routines in terms of how we go about and think about cybersecurity. And one of the things that I read that caused me to remember that it's always it's always important to remind people that time is of the essence as it relates to responding to information and responding to threats and responding to the things that we need to do in our environment. Tripwire produced one of its analytical reports here recently, and it said that advanced persistent threat actors are just as likely or more likely to exploit a known vulnerability as they are a zero-day one. And the zero-day attacks always get the most attention because everybody's the most worried about it because you don't know what it is until it happens. and you can't really do anything about it until it happens because you're not expecting it. But the fact of the matter is that they're just as likely to use something that's already out there, and because they share so much information now between the different groups. One group identifies a vulnerability, they share it out there on the dark web with all the other groups. And so when you see something come out, whether it's a patch or a fix or information with respect to a threat, it is really important that you respond to that in a very timely manner, because it's not unlikely that some other threat group might actually use that same vulnerability, if you will, to attack you. So pay attention to those things and pay attention to time when you're in your practices. The next one just kind of reminds everybody that ransomware is still out there, that ransomware is still very much a major threat in our environment. Verizon published its latest report, and looking at almost 24,000 cyber incidents that occurred, discovered that 25% of those, which roughly equates to 16 successful ransomware events a day, occur, which is amazing when you think about just the sheer numbers. And the fact that ransomware breaches increased by 13% over last year. So they're not going away. They're increasing. They're getting more complex. They're getting more sophisticated. They're getting more dangerous in terms of the things that they do and are willing to do to extort organizations. And they are still very much a huge portion of the threat that we have to deal with on a daily basis. This next one here kind of caught my attention, and it just reminded me that, we talk about attachments, we talk about documents, we talk about emails that we get from somebody that we don't know, or things that we didn't request. And it just reminds me that, we need to continue to pay attention to those things. We need to continue to pay attention to the attachments that are associated with messages we get from folks, and whether or not we open those attachments, whether or not we have the right protections on our network to make sure that those things are opened in a sandbox somewhere before they open on our network. But HP reminded us once again that we do need to pay attention to things like suspicious PDFs, because their team found a malicious attack, a keylogger malware attack that was actually taking advantage of PDFs that were sent as attachments to other documents. And it was really, if you go find it and read about it, it was actually a very sophisticated attack that took multiple steps, and that you wouldn't necessarily recognize right away. But the bottom line is, if you didn't request it, you probably shouldn't click on it and open it. And then the last one there reminded me again of just how things just continue to evolve. And this is important, I think, for all of us to understand and pay attention to. And this is why I read so much, and I hope all of you do that are engaged in this pursuit. And that is that everything we do is just evolving. There's a market out there on the dark web called the industrial spy market. That market has now evolved into using ransomware as a form of extortion with respect to the data that is sold or provided in that market, which is kind of a new twist. And the next question, of course, is, does that mean that all of those dark web marketplaces are going to begin to evolve to utilizing ransomware or extortion with respect to victims' data? And is that just another avenue of attack that we're all going to have to worry about? Again, something very important to pay attention to, because the threat just constantly evolves and constantly changes all the time. I throw these out. I pick different ones that just kind of remind us of things that I think are important and that we need to constantly remind ourselves of as we're thinking about the threat, and we're thinking about how we respond to it, and we're thinking about what we tell our users to help them do a better job of avoiding some of the things that can really create problems for us. Next slide, Sophie. There's a new law in Connecticut. If you haven't read that there's a new consumer protections law for privacy It's very similar to CCPA out in California and the CPRA, but not quite the same. It's more similar to the Virginia and Colorado privacy laws that were passed, but again, not exactly like those either. But one of the things that Andrew's team is going to do is they're going to actually sit down and develop a comparison chart for these laws. And any of you that are interested in seeing that chart once they're finished with it, so that you can understand the difference between the new Connecticut law, for instance, and the Colorado, the Virginia, or the California laws. All you have to do is request it, and we'll provide it for you. But if you do business in Connecticut or do business with Connecticut citizens, it's important for you to know that there's a new privacy law out there in Connecticut that you're going to need to pay attention to. Next slide. So I keep this up here because obviously things are not settled over in Europe, and so until that is settled or until that is over, and I'm not even sure if when it's over, this is going to necessarily go away. I think we always have to be vigilant with respect to things that we see coming from overseas towards our network. But right now, in particular, you need to maintain your vigilance with respect to threats coming from Eastern Europe or Russia in particular. And again, if you see anything that doesn't look right or looks suspicious, please report it to either CISA or the FBI, because the thing that you report may be the thing that saves somebody else, keeps somebody else from being harmed. So please make sure that you report anything that you see that doesn't make sense. Next slide. So this one was one that kind of jumped out at me, and part of the reason it did is because the last month I've had a couple of occasions where I've had conversations with folks who have had incidents, who unfortunately had problems when it came time to recover because either their backups were impacted by the attack along with their production data, or their backups weren't ready for restoration like they thought they were. And in both cases, they didn't have a copy offline that was completely separate from the rest of their environment. And I went back and did a little research after I had those conversations, and this apparently is still a bigger issue than probably what I would think it would have been. And unfortunately, people are still not thinking about this concept of, even though we may have very sophisticated backup protocols, et cetera, and multiple backups, all too often the attacks that we're seeing today are affecting both the backups and the production environment. And when that happens, if you don't have another copy somewhere else that's not online or not connected, at least for your most critical systems, then you're going to be down, and you're going to be down longer than you would like, or longer than you expect. There's a simple rule out there that you hear all the time, the 3-2-1 rule, which basically says I have 3 sources for the data that is critical that I need, two backups that are separate, and 1 offline. And it's that 1 offline that we need to pay attention to, because it's that 1 offline that's air gapped that's actually going to save us when there's a real sophisticated attack that hits all parts of our network and our backup and et cetera, and give us the ability to recover at least those things that are most critical that we need to absolutely run the business and care for patients or do whatever it is that we do. And so we need to think about that. We need to think, what do I minimally need to run this business or care for my patients if my network goes down? And that at least minimally ought to be backed up offline, away from the rest of your network, so that it isn't reached or touched when your network is potentially exploited. Next slide. Next, you hear me talk about going offensive all the time, and I'm a big believer in that. I don't like just sitting there waiting for the bad guys to come at us. And you've also probably heard a lot of the cyber insurers talking about EDR as one of the things that they think everybody should have in place, and I don't disagree with that. And I think this is one of the solutions that we need to be considering if we don't have it, because EDR is indeed something that actually allows us to be more offensive in our protections than defensive, because it's sitting there actively monitoring all of our different endpoints and systems and communicating to us when it sees something that doesn't make sense or that looks like a threat. And so think of it as the listening post, if you will, for Chesty's regiment out there that's kind of listening for the enemy to approach. They're being offensive. They're not waiting for them to come. They're putting people out front. They're getting out there far enough out in advance that they can hear the enemy coming soon enough that they can actually be prepared for them when they get there. That's the same thing that EDR does for you. But EDR also not only helps you monitor what's going on in your environment. EDR can obviously take action and stop a lot of the things that can affect your network. It can work with other systems within your network to deflect or to stop various attacks. But the other thing that it does is it gives us that record afterwards, that when we're trying to figure out exactly what the threat or what the malware did and what systems it affected and what data might have been affected by the attack, it gives us that record, if you will, of all that information that allows us to do that investigation a lot quicker and a lot more accurately. So if you don't have an EDR solution today, I recommend highly that you give it some thought and understand that it is part of an active defense that helps you be more offensive in fending off threats than something that just is sitting there waiting for the bad guys to come. Next slide. So with that, I'm going to turn it over to the real experts, and Jon Benedict is going to be up first. And as I said, John's one of our medical device security principals, and he's going to be talking about medical device security. And then after Jon finishes, Andrew will be up talking about the 8 exceptions to the information blocking rule. And then once we finish that, we'll come back and answer some questions and talk about what's coming up in July. Thanks.
Awesome. Thank you, Mac. Thank you for the introduction. Hello, everybody. Jon Benedict. I'm glad to be joining for the first time. I joined CynergisTek back in March, and we are working very hard on building out a managed service for medical devices. So what I wanted to do is basically talk through building blocks of a medical device security program, a few different models, and then go through some active threats. And then the last thing we want to talk about today will be the FDA pre-market guidance. Next slide. So first and foremost, what are the components of a medical device security program? As Mac mentioned, I've spent a lot of time in the trenches at a lot of different sides of this, and I've either worked for or done consulting on behalf of pretty much all different sides, OEMs, technology partners, service organizations, what have you. What we found is 4 basic building blocks, and they all fall under people, process, and technology in some varying form. But we found the first and foremost one, obviously, an accurate identification and location of the medical devices that are connected. We learned during COVID how valuable it was to have location on some of these devices, not just from a security perspective, but from a usability perspective. So we've added that location piece here. I think the identification speaks for itself. When we started out, really the journey in cybersecurity for medical devices, think back to WannaCry and think back to that first time when we tried to match an IT inventory with a biomedical inventory. Struggled a lot to have MAC addresses, IP addresses, et cetera. And so just having an accurate identification of that, of your connected medical devices is just critical as a building block. From that point forward, we look at assessing the devices, and we assess them on really two axes, if you will: serviceability, keeping them up and running, keeping them available for use when they're needed, and then the IT security component. As we've learned recently, security really is a patient safety issue. If a device is down because of denial of service or any other reason related to IT security, it's just as unusable and sometimes even more dangerous than a device with a mechanical flaw. The third component is the clinical engineering team. Invaluable. The men and women that maintain these devices, their expertise on what makes them run, it just can't be understated. I could go and patch a device any day of the week, but what I don't know how to do really well is I don't know how to reboot it and make sure that it's safe for patient use after a patch or an upgrade has been installed. So that team is really, really important here. And then, of course, your network and security teams. Network and security teams often struggle with the differences and nuances in medical devices. I know those of you who know me, you'll hear me talk about medical device security as taking care of the island of misfit toys. Nothing makes sense. Nothing is standardized, even from the same OEMs, even using the same protocols. Nothing seems to be standard. So helping those network security teams understand why you can't necessarily push WSUS patches in an automated way, or why you can't just block by default because that could impact patient care. So making sure you have a network and security team that understand the nuances of those teams. So you really need all four of these attributes kind of working in perfect harmony to have a successful program. Next slide. So then we looked at three basic models of how do you deliver this. And in all my travels, I've seen three basic models. When I was talking to Mac about this, you see a full in-house team that the organization has clinical engineering, IT security, all their own people managing everything. The second team is a hybrid. Maybe you outsource a piece of it, clinical engineering or an IT team or security, what have you. And then the third basic model would be full outsourcing of all three of those teams. What I want to be really clear in is there's no right or wrong answer here. There's no one way that's better or worse. It really comes down to a lot, as we'll talk about in the next few slides, resourcing, expertise, and really having a solid plan on how to deliver this. There's, I think, some strengths that each one of these bring, opportunities for improvement or gaps that I've seen commonly surface. So let's talk about a few of them. Next slide. Full in-house team, commonly observed strengths, streamlined governance. Everybody's on board. Senior leadership has given the directives, and in a perfect world, you have full control over all four required areas. And you have funding, and you have all the tools and technology you need. Most commonly observed gaps with this model: challenges to hire, train, and retain talent. We've been talking about this the last couple of years. Finding good people that understand both clinical engineering, medical devices, and network and IT security is very difficult. It's very difficult to develop an IT person into a biomed, and it's very difficult to develop a biomed into an IT person. I've tried it both ways. Again, no right or wrong answer. None I don't think is easier than the other. They're just difficult. And then the other commonly observed gap I've seen is, when you have a deficiency, demonstrating ROI, budget needs. If we're going to invest in certain things, obviously the equipment speaks for itself, but equipment and security are kind of your highest line items outside of your physicians. And so demonstrating why you need a tool, demonstrating why you need additional team members, I've seen this to be a challenge. So, being able to say, hey, leadership, I need 3 more bodies because I need somebody who can do risk assessments on devices. I need somebody who can hunt down vulnerabilities, and I need somebody who can integrate all of these tools. So anyway, next slide. Hybrid team. I think this is the most commonly one that I've seen out in the wild. You have one piece of it outsourced, whether that's biomed or clinical engineering, whether that's IT. Very, very common to have one or more teams, but then also have some of your leadership team or some of your other teams in-house. The strengths here are the resource challenges should be alleviated. You should be able to bring in expertise or have your vendors or partners bring those in at a more attractive price point for you. And you should be able to have service level agreements that clearly define the metrics and the deliverables. So if you do those couple of things, you should set yourself up for success. Most commonly observed gaps in this is I've not found a lot of vendors that cover every single piece, and then piecing all of those things together. So people, process, and technology that cover identification, that cover management of risk, serviceability, clinical engineering, and so finding that vendor or set of vendors that cover all the components, I've seen as a challenge. And then I've also seen that as a side effect, direct oversight and management of those teams can become difficult to deliver a cohesive solution. That one seems to surface itself all the time. And no matter what you have for a playbook or a racing matrix, things just seem to fall through the gaps. So, what I'd give as advice if you have a hybrid team is have solid processes, have policies, have a racing matrix that clearly defines who's doing what. And even with the best playbooks and races, things will slip through, but always use those as opportunities to improve process and catch those things on the next one. Next slide, please. Full outsource team. We see this less and less, but it's still out there. And observed strengths here, very similar to the hybrid team. Your resource challenges should be alleviated. Your service level agreements are also important. But what I found here is same challenges in terms of covering all the facets of a program. But what I'm also starting to see now is with your outsourced teams, they are facing the same resource challenges, attracting, retaining really talented people. So keeping those people with your program once they get up to speed and know it, I've seen that as a challenge as well. This one too, really you're going to wind up almost having to have a team or certainly a couple individuals that take on vendor or partner management full time, because keeping all of those pieces in working order and making sure your SLAs are met and your deliverables really turns out to be quite a challenge. And I know that's one area that I've seen struggle. Okay, let's move on to the next one. Now we'll start talking about some fun stuff. Moving from discovery to manageability. So we've got our 4 pillars in place. We've got tools in place. We've got an up-to-date and accurate inventory. We've seen a lot of new passive tools that do a great job with medical and IoT devices. And so what this has given us is a ton of data, a ton of visibility. So is this better? Is it worse? What I found is it's both. It gives us a lot of visibility we didn't have before. As I said earlier, WannaCry opened our eyes. Our first efforts after WannaCry were sneakerware. We sent people out manually to collect the data and then manually upload and type data. I don't know about anybody else. If I try to type in 4 MAC addresses, I'm liable to make just a fat finger error within just a couple. So it has its challenges. Now we have these tools and we have the data, and now how do we integrate it? And how do we secure the data? How do we make sure that as we're integrating into a NAC or a SIM or a SOC, that all of that data is secure, that we're ingesting it, that we're not just burying ourselves alive in alerts. So, what I found is that the tools are great, the data is great, but without the people and process behind it to put into place and really manage the playbooks, manage all of those efforts, this can become a challenge. But that's where we're at in our journey, right? We have tools, we have data, and now we have to figure out how to wrangle this and manage it. So let's go to the next slide and talk about that. So how do we build a successful medical device program? Obviously, visibility is important, but this really comes down to the people and process. We still need well-trained cyber analysts, people that, like Mac was talking about, they're going out every morning and looking at the threat matrices out there, looking at what's being targeted. When we get into one of these next slides here, we're going to talk about literally using old vulnerabilities versus 0 days. But back to your building your program, integrating into your technology stack. Adding tools is great. Adding visibility is great. But now we need to get real-time visibility on our medical devices in the same way you have it on the rest of your enterprise. You need to roll that into a comprehensive incident response plan, have nice detailed playbooks so that when an alert happens, you know exactly what the clinical engineering team is doing. Are you authorizing them to take a device offline? Are you going to wait, and who's going to be the play caller on all of those? And so the most important message I have here is it doesn't matter which model you use. It really doesn't. What you need to do though is make sure you've got a full cohesive program that covers all 4 pillars, and that you have really good playbooks, processes, and procedures in place to address things, because this is an ever evolving world. It's not perfect. It's going to change every day, and we need to be able to move and evolve quickly with the threats that are coming at us. Next slide, please. So let's shift a little bit and talk about some current medical device threats. Just as Max said, the last couple of months, oddly, we've seen really old viruses like Conficker, spyware like Pegasus showing up on imaging devices. I think when I looked it up, Conficker came out in 2008 or something like that. And so I think that really speaks to the fact that attackers are just as likely to use an old vulnerability, especially if their goal is to get into a healthcare organization, because they know that a lot of these medical devices have been in service for 10 or 15 years, that they're likely running older, unsupported, and probably unpatched operating systems. What's the root cause? One thing I've learned in the last few months is determining an absolute root cause on a medical device is a lot easier said than done. Getting real forensics, even doing a bit level of the hard drive, still weren't even able to pinpoint when some of these came in. So we just had to use some good old fashioned horse sense here and say, well, if it was Conficker, did it come in 2008? Has been sitting dormant? Was there a change in a firewall rule that's now allowing us to see this? Or did it come in at some point when somebody serviced the device? Probably something more like the latter. It probably hasn't been there for 15 years, but was probably brought in somewhere, and a change in a firewall rule has allowed us to see it. Spyware. How does Pegasus get on to a medical device? Almost had to be somebody plugging in a mobile device. I'm not sure that I've heard of it being used elsewhere. I'm sure it could be, but to me, that's always been an attack on mobile devices. It was going around a few years ago. The other big place to look in your network that I'd recommend to everybody is your sustained B2B connections, particularly those that are transmitting DICOM. And every healthcare delivery organization has them. You have doctors, you have clinics, you have radiology reading services. So do yourself a favor, go back through those persistent connections, go back through and make sure that they're configured, that you are doing your point-to-point encryption on those tunnels that you can, and just make sure that if something's going outbound, that it's intended to go there. So it only takes a few minutes to look up the owner of an IP address and a few phone calls or emails to figure out if they're a signed business associate. do yourself a favor and do that homework because it will pay dividends for you, especially I've seen this where other organizations have been hit with ransomware, and to know that you have an existing connection with that organization allows you to sever that tunnel quickly and cut off your opening there. So do yourself a favor and spend some time looking at those connections. Okay, next one, please. So FDA pre-market guidance, as many of you know, on April 8th, I think it was, the FDA released some initial pre-market guidance. I'm not going to read the whole slide to you. It's not final. It's open for comment until July 7th of this year. If you want a link to be able to provide commentary, please reach out to us. We're happy to provide that for you. The biggest point here is that it's looking to actually go beyond the MDS2s, and it's really targeted a lot of its discussion on the software bill of materials. And really, what is that software bill of materials? And more importantly, what are we going to do with that data? So as we found the last few years trying to build a program, the MDS2 only took us so far. And then as we're reaching out to manufacturers for their software bill of materials, we realize this is very difficult for them. They can build it one way and get it approved through the FDA one way, but then it goes out the door, and then there's quite often other software added on. So getting at least the way it went out the door from them is going to be a huge step in the right direction for us. Let's go to the last slide here. So highlighting that, right now today, neither MDS2s or SBOMs are required by the FDA for approval. But what this will do is allow a little bit more clarity into what's going in pre-market. So there's a lot more visibility there. What we're encouraging our clients to do as a consumer is really just, as you're procuring the equipment, demand an SBOM, make it a prerequisite for procurement. Take that data, import it into your CMMS, into your CMDB, and really start driving for that. You know, it took a few years to start getting MDS2s, and I think SBOMs are going to be coming along as well, and I think that will help us all moving forward with security. So with that, I think that's my last one. I want to thank you all for tuning in and hand you over to Andrew.
Thanks, Jon. Thanks, everybody, for being here. It's nice to be speaking with you again today. As Mac mentioned earlier, we're going to continue the conversation around the 21st Century Cures Act and information blocking specifically, and I'm going to dive in to the 8 exceptions to the rule. And really the question here for this presentation, you know, we know that the information blocking rule requires us in certain circumstances to share data, share information, but what if we can't? So let's dive into those exceptions. And Sophia, next slide, please. Great. So we started this last week. I briefly touched on the 8 exceptions, and you can see here the ONC provides a lot of very helpful information. Encourage you to go and look at their website to dive a bit deeper. And this graphic is taken directly from them, and you can really dive deeper if as you need to. Next slide, please. Sophia, can we get the next slide if you can? Oh. Okay, thank you so much. Looks like we're back. Some foundational questions about information blocking first. What if our policy prohibits sharing to certain individuals or entities? What happens if we can't share or we're unable to share EHI? What happens if we can share data, but we need to have certain conditions met first? So things like patient consent or licensing. And then what about when it's impossible to share EHI? So what about in a natural disaster situation? How do we navigate some rules that tell us we're required to share data and we may be penalized for not doing so? So the next few slides, we'll go through the 8 exceptions and we'll give some examples too And just know going into this, each one of these exceptions is pretty detailed. So you want to make sure as you're assessing, information blocking in general, looking at these 8 exceptions, make sure you're doing it thoughtfully and with all of the right stakeholders within your organization. Next slide, please. Okay, the first exception. This is the preventing harm exception, and this is something that probably many of us are familiar with in the compliance space. There has been, lots of discussions around how we disclose data to prevent harm. This exception, within the 21st Century Cures Act, it really recognizes that there is a strong interest in protecting patients and other people against unreasonable risks, and that public interest can justify certain practices that are likely to interfere with certain disclosures of electronic health information. But there's a few conditions that have to be met first. And, like all the other 7 exceptions, you'll see these conditions that are very specific, but again, everything's on a case-by-case basis, and you'll need to really dive deep into the circumstances to really make sure you feel comfortable when you're not sharing data. So first, you have to have a reasonable belief that the practice will substantially reduce a risk of harm, and that belief can't be broader than necessary. So you can't, for example, restrict all data for a certain issue when maybe you only need to restrict a certain data set. You have to consider the type of risk. So are we using professional judgment here? What types of risks are really coming up for our patients? We have to look at the types of harm. In this case, it's very similar to the HIPAA privacy rule here, harm to others, harm to themselves. And then we need to make sure this is implemented under a policy or a very clear determination. And then finally, we have to satisfy the condition that we allow a patient the right to request a review of that determination of risk of harm. So this is where it takes the HIPAA rule a bit further. Let's look at some examples to try to help this play into real life for a minute. Example A, we've got an ordering clinician who requests to review the results in order to personally inform the patient of the results. In this case, probably would not be a valid exception. There may be certain cases when it could be, but if a clinician is just simply saying, I want to review the results first, and it's going to take me a couple days, and I want to have the conversation with the patient before we provide it to them. If the patient or somebody else has requested, we need to be acting on that without unreasonable delay. And in this case, could be unreasonable delay. And then example B, same clinician informs you that the records of minors must be provided to guardians before it's released to them. We'll see in the next exception how this could play into a valid exception. But in this case, again, we're not seeing any real risk of harm being articulated. We're just seeing in this case somebody saying, I think we need to give the records of minors to their guardians first. So these are a couple examples here, in sort of the real world where we're thinking about, are we actually preventing harm when we're not disclosing data, and are we doing this in a thoughtful and considerate way? Next slide, please. So the next exception is the privacy exception. This exception states that we're not going to be required to use or disclose electronic health information in a way that's prohibited under state or federal law. So let's look at some examples here. A provider informs you that the health system can't release substance abuse records prior to a written consent from a patient. Well, in some cases, we know that with 45 CFR Part 2, other types of privacy laws and rules, we may have to obtain a consent form before we actually release the records. This exception makes that permissible. Let's look at example D. A psychiatrist asks you if they can deny release of psychotherapy notes. Now, this goes way back to the HIPAA privacy rule. And in this case, we know that under the HIPAA privacy rule, providers can restrict the release of psychotherapy notes. And there's many, many reasons why this is the case. But in this situation and under the 21st Century Cures Act, again, another example of where this exception could be valid. It could meet the exception, and it could permit you to essentially not share information even when it's been requested. 2 points to consider here. We have to have the denial of the request consistent with the HIPAA privacy rules. We have to allow them an ability to review why that was denied. And we also have to respect individuals' requests not to share information. This goes back, in the prior slide mentioned, releasing records to minors. We know that under the privacy rule, we have to permit individuals to tell us how we can and can't share data and with whom. And in a situation like that, if a minor or other tells us, my data cannot be shared with this person under applicable state law, that's going to be an exception to the information blocking rule, and we can share the data. Next slide, please. The security exception. This is intended to cover all of the security practices by really any actor. So again, thinking of providers, health information exchanges, health IT developers. But similarly to the HIPAA security rule, there's not really a maximum level of security. There's not a one-size-fits-all approach. What they are communicating here in this exception is sort of an understanding that practices are going to be different for entities of different sizes and shapes, and that could mean that certain security practices may prohibit or restrict certain releases of data. So let's look at some examples here. We'll dive right in. General Counsel reports back to you that some third-party applications have to go through extensive security assessments prior to implementation. Well, something that is a clue here that this may not meet the exception is extensive security assessments. We cannot take extraordinary measures to prohibit the release of records. We need to have due diligence, have our due diligence processes in place, have our security measures in place, but we can't just select certain applications and say they have to go through more in-depth assessments or questionnaires than others. And then example F, you've got an intern who comes to you and says certain proposed security measures can't be implemented. So again, these security measures related to the release of information can't be implemented until the organization performs a new security risk analysis. Those of you on the call who have gone through an RA process know how extensive this can be. It can take a lot of time and a lot of resources to go through a full risk analysis. And ONC actually tells us if you have a request and you have the ability to implement the technology and to release the records to the person requesting, you need to do it. And you can't take these extraordinary measures like setting aside a whole risk analysis before you do that. Next slide, please. Infeasibility exception. This recognizes that an actor may not have and may be unable to obtain certain technological capabilities, legal rights, or other measures to really facilitate the access, exchange, or use. So let's go right to an example here. Your office is receiving an extremely high and rare number of requests in 1 week. Staff are working on many other urgent items, and the manager of, let's say, health information management recommends responding to certain providers first and prioritizing providers serving in leadership roles. This would not be an example of a valid exception, and ONC speaks to this directly. You can't use an overworked workforce as an excuse to say this is infeasible for us to release the records. What you can do is you can provide a written response to them and let them know within 10 business days why it's taking you a bit longer to obtain it and release it. But you can't single out certain providers and say they're going to have priority over others because our work needs are too heavy. Next slide, please. The health IT performance exception, really the gist here is this recognizes that in order for our technology to improve properly and efficiently, sometimes we have to take it offline, right, and make some upgrades. So let's look at an example here. You realize that you plan an international trip in the middle of an EHR upgrade, and you're worried about telling leadership that the EHR is going to be down for a few hours in the early mornings, and we're not going to be able to respond to requests. Well, in this case, ONC tells us specifically, this is an exception to the rule. As long as it's implemented for a short period of time, no longer than necessary, then we can delay the release of records upon request if we're doing some management around our health technology. Next slide, please. The sixth one, we're coming up towards the end, content and manner exception. We've got a couple key issues here. One I spoke to last cyber briefing, which is that on and after October 6th of this year, you have to respond to requests with the electronic health information requested. And we have to generally fulfill that request in the manner requested unless there's a technological issue or we can't reach agreeable terms with the requester. In those cases, we still have to look at fulfilling it in an alternative manner, in a machine readable format, providing access to them in a way that's meaningful and meets their request. So let's look at an example here. A request for a full record through you receive a request for a full record through an iOS application, and your system tells you we're not compatible. There may be some things here that would fit inside of an exception, and because you technically do not have the ability to work with this application. However, you need to work with the requester to figure out if there are alternative ways you can provide the same or similar data to that requester. So just because you can't do it in one way doesn't mean you can restrict it across the board. Next slide, please. Fees exception. In this case, it allows you to charge some fees related to access, exchange, or use. I will say that from my experience talking with ONC and with OCR, charging fees is something that is frowned upon in certain cases. They know that this is going to happen, and we're going to have to charge fees in certain cases. But in general, the push is to provide access cleanly, clearly, transparently, and without cost. So just know that that's the wave of enforcement. They're really hoping to see people move away from assessing fees for records. However, you can do it. So let's look at an example here, and we'll see whether or not this fits within an exception. You live in a town that only has one other hospital, and your organization policy says we're going to have to charge records for an export of EHI when another hospital in town requests access because we need to retain our patients, and we don't want them going next door to the other hospital. This probably would not meet an exception to the rule. And in this case, it's because we're essentially discriminating. We're saying we're not going to release it to specific hospitals because we don't want the competition. So you cannot charge fees in those types of circumstances. But as long as you're charging, as long as they're reasonably related to your cost of providing certain types of access or exchange, you can do that. Would encourage you to look at your state law requirements around fees for medical records, as well as your organizational policies as well. And now we're going to the final exception. Sophia, if we could change the slide, please. The licensing exception. In this case, it allows you to protect the value of innovations, and you can charge some reasonable royalties. Really, I think for the majority of you on the call, those of you who are working in provider contexts, you're probably not going to see this exception come up. This is primarily going to be related to health IT developers who are licensing and developing technology, licensing it out, obtaining royalties, and so forth. But let's look at an example, nevertheless. As an EHR, and this is assuming that we're an EHR organization, we've got a policy that permits charging vendors different prices based on pre-existing business relationships. In this case, again, we're seeing a form that sort of starts to look like discrimination because you're not treating all of the organizations equally. You're singling out those that have pre-existing relationships with you. You may not be able to meet the exception in this case. Again, probably not going to apply to a majority of you, but important for you to know nevertheless. Next slide, please. So with all of this being said, the time to assess is really now, right? And we've talked about this before. A few things to keep in mind. First of all, do you have a policy that addresses the 8 exceptions? Who drafted that policy and who was involved in implementing it? Did you have all the right stakeholders from technology, HIM, privacy, compliance, general counsel? Who is reviewing the exception? So 3 and 4 are really not mutually exclusive. How are you reviewing them? Really consider implementing some decision trees here that will help your staff navigate some of these complex issues, and making sure that you have somebody on point or an office on point who's responsible for assessing. And then finally, where you have the ability to respond or there's a requirement to respond back to the requester, have some templates in place. It makes life a lot easier for you. If you can have the template, you can fill in the blank and move on. Next slide, please. And then finally, a few things to remember. Your documentation for these exceptions, it needs to happen at the same time that you're making these decisions. They need to be implemented in consistent and non-discriminatory manners. So you see this throughout the exceptions, and that's why I've mentioned that throughout this briefing. If you make EHI accessible and usable, there's relatively a low likelihood that you're information blocking. So keep that in mind. If you're making it accessible and usable, you're probably not, you're not in this area of enforcement. The exceptions that I talked about today, these are all voluntary. So just because you meet an exception doesn't mean you have to use one, but they're in place for you to use on a voluntary basis. And then finally, just know from an enforcement perspective, they're going to be looking at practices on a case-by-case basis. My guess is they're going to look at some of the exceptions around security measures and security practices because that's so broad. So keep that in mind as you're thinking through information blocking and making sure you have good policies, practices to facilitate access to data. And with that, I will turn it over, I think, to Mac.
Okay. Thank you, Andrew. Thank you both, John and Andrew, for sharing your time and your knowledge with us. And with that, I know we don't have a lot of time left, but if there's questions out there, we'd like to try to entertain some. So, Lauren, are there any questions?
No questions as of now, but let's give a few seconds for.
Yeah, let's give everybody a couple minutes. Remember, you've got the tab over there on the left where you can ask them. And I have a question for you to think about. So just to give you kind of a preview, next month we're going to have a speaker who's been very much involved in working GDPR with a lot of folks, talking about a topic around GDPR. And then we're going to have another member of our security team talking about an approach to implementing PAM, or privileged access management, and the things that you need to consider in those implementations. So if there's anything that you would like, in particular, any questions that you have with respect to either of those two topics that you would like us in particular to talk about next month, ask that question as well.
Okay, Mac, we do have a question.
Okay.
What is the real threat from Russia on healthcare organizations? Is China still a threat to healthcare?
I think the short answer is you have to always consider both Russia and China a threat. And the reason I say that is because the majority of the advanced persistent threat organizations that are out there that are involved in a lot of the major cyber incidents that we see are protected by both those countries and reside in both those countries. So you, regardless of what's going on in the world, on the world stage with respect to Ukraine, et cetera, you always have to consider Russia and China, or at least the cyber groups that come out of Russia and China, as a threat. We know that China actually sponsors advanced persistent threat groups that collect information against other countries, to include the United States, for state purposes. We know that Russia does that as well, from information that our intelligence community provides us, and the threat warnings that we see out of CISA and the FBI. We know that they've been behind a lot of the major attacks that have occurred in healthcare, and some of the biggest attacks that we've seen in healthcare. So I think the short answer is yes, you always have to consider China a threat, and as well as Russia. And I think just right now, as a result of what is going on overseas in Europe, and the unknown with respect to how that could or could not escalate, it's one of those things where they bear closer watching right now. But I think, but to answer your question, yes, they absolutely are a threat.
Okay, Mac, that is it for questions.
Okay. Well, listen, thank you very much, all of you, for taking time out to share, to spend with us today. I hope you found something from both John and Andrew's presentation useful. Like I said, next month we're going to be talking about 2 new topics. If you have any questions with respect to that, please feel free to submit those. If there's a particular topic that you would like for us to talk about on one of our cyber briefings, please let us know, and we'll try to cover that. So thank you very much for coming today.
All right, thank you, everyone. And just a note, our next briefing, our July briefing, will be on the second Thursday, July 14th. So instead of the first Thursday, it'll be July 14th, just due to the holiday. Thanks for joining us.